हेलो गाइस, वेलकम टू रैपिड रिवीजन आईसीयू सीरीज। तो आज हम बात करेंगे मेनिंजाइटिस के बारे में। ये बहुत ही इंपॉर्टेंट टॉपिक है, आ सकता है। इसमें हम क्या क्या देखेंगे। सबसे पहले चीज़ कि हाउ टू क्रिटिकल केयर अप्रोच अपडेटेड टू WHO 2025 ग्लोबल रिकमेंडेशंस एंड करंट CDC गाइडेंस। So what it shows is treat first, then confirm in parallel, and never delay antibiotics. The main thing we have to focus is never delay antibiotics for imaging or LP when the patient is unstable. So what we do is LP, which we do for CSF, then we give antibiotics, then we should also give steroids with first dose of antibiotics, then ICU support. So this is what meningitis is about. These are the WHO 2025 recommendations that we should never delay antibiotics for imaging or lumbar puncture when the patient is unstable, and we should give steroid with first dose of antibiotics. Now we have to recognize the syndrome early. How? With presentation, that is fever, headache, neck stiffness, photophobia, altered consciousness, seizures, or meningococcal rash. These are the presentations of meningitis. And the likely pathogens which we have to remember are Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenza. These are the most common ones. And add Listeria coverage when age, that is extremes of age or host factor risk increase. Alright. Why ICU care matters? Because meningitis patients always land up in sepsis, shock, raised ICP, cerebral edema, cerebral infarction, hydrocephalus, seizures, and hearing loss, which drive outcome in these patients. Okay. So the first priorities at the bedside should be to secure the airway and hemodynamics, drop blood cultures before antibiotics whenever possible. You start empirically with ceftriaxone or cefotaxime immediately. Add Listeria or resistance cover when indicated. A meningitis plus sepsis presentation should trigger parallel workup and treatment, not sequential waiting, which we discussed earlier. Alright. Any shock, focal deficit, seizure, or depressed consciousness raises urgency and increases the need for brain imaging before lumbar puncture. Alright. So guys, when we should do imaging before lumbar puncture? Okay. So routine cranial imaging is not recommended. So these are the WHO guidelines. Imaging should be done only when the risk of herniation is higher. Alright. So how we know that it is risk of herniation is higher? At presentation, GCS would be less than 10. Recommended action, image before lumbar puncture if readily available. Otherwise, defer lumbar puncture and start antibiotics. If there is focal neurological signs or cranial nerve deficit, we should do imaging before LP. If there is papilledema, then we should do imaging first. If there is any new onset seizure in adults, we should do imaging first before LP. If the patient is severely immunocompromised, then we should do imaging before lumbar puncture. The key point here is to note that if lumbar puncture is deferred, obtain blood cultures and start antimicrobials immediately. Treatment should not wait for imaging. We should remember that. So now usually the cultures take 2 to 3 days to come. But we have rapidly CSF analysis which point towards bacterial meningitis before cultural results return. So the typical CSF patterns, we should remember these by heart. So opening pressure would be very high in bacterial meningitis. It is somewhat normal in viral. Appearance always turbid or cloud in bacterial meningitis. Viral, it is usually clear. WBC will be very high in bacterial meningitis. In viral meningitis, it will be lymphocyte predominant, and in bacterial usually neutrophil predominant. Glucose would be low because bacteria consume glucose, so there will be low CSF compared to blood. That is ratio is less than 0.4. Protein would be elevated, and gram stain or culture may be positive. In viral cultures, usually normal to mildly raised picture will be there. Alright. So guys, now comes the treatment. So empiric antimicrotherapy should be given before the cultures are present. So how would we estimate that which antibiotic should be given? So most children more than 1 month and adults should be given IV ceftriaxone or cefotaxime. That is, reason being WHO first line empirical therapy is there because it is most commonly due to common bacterial infections. Then if there is listeria risk, then we should add IV ampicillin or amoxicillin with ceftriaxone or cefotaxime because these two covers listeria monocytogenes. Okay. Then if there is high pneumococcal resistance, then we should add vancomycin because it improves resistant pneumococcal coverage. Okay. If in some countries third generation cephalosporins are not available, then we should add chloramphenicol. Okay. And if there is meningococcal epidemic at present in that area, then IV ceftriaxone would be the preferred first line during epidemics. Okay. So what we should remember is that if there is non-epidemic duration and if the pathogen remains unknown, consider stopping after 7 days of antibiotics if the patient has clinically recovered. Okay. If there is meningococcal epidemic, then we should give ceftriaxone for 5 days. If there is pneumococcal, then usually that will be higher mortality. So usually give 10 to 14 days. WHO suggests at least 10 days as a practical default. We should remember this. Other than antibiotics, we should also give injective steroids and ICU bundles. So steroids always with first antibiotic dose. In non-epidemic settings where lumbar puncture can be performed, give IV corticosteroids with first antibiotic dose. Stop if CSF is not consistent with bacterial meningitis. So when to avoid corticosteroids, it should be not routinely used during meningococcal disease epidemics. If bacterial meningitis is supported and streptococcus pneumonia H influenza type B is indifferent, continue for a maximum for 4 days. So duration signals how much time we should give. If the pathogen is unknown and the patient clinically recovers, empiric antibiotics may be stopped after 7 days. Acute symptomatic seizures generally do not require anti-seizure therapy beyond 3 months if there are no recurrences. So this is the timeline, 3 months. What comes under ICU care bundles? So what we normally do in ICUs, airway and oxygenation, circulation with vasopressors, glucose and sodium checks, seizure treatment and EEG if needed, temperature control and GCS check, droplet precautions when meningococcal disease is possible. So we should escalate early for shock, depressed consciousness, persistent focal deficit, hydrocephalus, or if there is issue of raised ICP. So we should act accordingly. So guys, these are all the latest recommendations from which we have made the slides, which is WHO guidelines on meningitis diagnosis, treatment and care, and WHO guidelines on meningitis diagnosis, treatment care, NCBI bookshelf version, and as per latest CDC guidelines for meningococcal disease and about meningococcal bacterial meningitis. All right. Hope you have a good time. Thank you.